So TB continues to be the top infectious killer worldwide, claiming 4,500 lives a day. It is estimated that approximately 1% of the global population is autistic. So if you're on a medical aid, how well do you understand the benefit structure and how your medical aid generally works? And if you're not on a medical aid, have you considered belonging to one? So how much and what should you know about this condition? Is it curable? Can people living with epilepsy, for instance, play sport, drive cars, get employed? 7 million people around the world die annually as a result of tobacco use.
For Health Tip, catch Health Talk every Saturday from 9 to 10.
Fraud is a criminal offense, and there we define it as an intention to misrepresent facts. And in the case of healthcare, this would relate to claims that are submitted to schemes or administrators. So there's an element of illegality in fraud. When it comes to waste, we look at basically overutilization or over-servicing. So here we're looking at the necessity of the requests that are made. The third part is abuse. The request, is it in line with protocols or what is taken to be standard practice? So here we're looking at the correctness of the event.
There needs to be a separation from waste and abuse and fraud. Yeah. And we should stop looking at it as a continuum.
Right.
Yeah.
Because it creates problems.
Yeah.
Waste and abuse are system design, and there are other factors that go into it. Fraud is criminal activity and needs to be treated as such. And the problem is that it keeps going up because we've made fraud an industry and not a criminal activity.
The scheme rules, our rules are very clear. If you participate in any fraudulent activities, we, apply a zero tolerance. Whether you're a provider or a member, you can be, terminated. Your membership will obviously be terminated. And also criminal action can be taken.
What we advise our members is that they shouldn't do any favors for their patients. Like the situation that has been stated where you see one patient using the other person's name, it starts from there. And very soon they'll be asking for money, for advances, for letters, and then it just escalates, and sooner or later the practitioner will find himself in an envious position where he's charged for fraud.
So last week we understood the nature of this problem of medical aid fraud. Now the big question then is, what is being done about it? How are medical schemes and administrators dealing with this problem? And how can it be prevented? Now that's our focus for today as we continue our discussion on medical aid fraud. Now we still have a guest panel comprised of medical aid executives from GEMS and Bonitas, also executives from the administrators Med Scheme and Metropolitan Health, the Health Professions Council of South Africa, Council for Medical Schemes, MD of the Board of Healthcare Funders, practicing medical practitioners, and somebody from the South African Medical Association, and of course we have an audience of industry stakeholders. Now you can tweet us at SABC Health Talk or simply just interact with us on our Facebook page, SABC Health Talk. Now sit back, relax, and learn from this bumper show ahead. Coming to you just after a short break. I'm Dr. Selong Daung, and this is Health Talk.
nje nathi nana njengabahlali balana and then nje masihleli lapho siyajathi nje sinamajida ngale sibona ismoke siyaqhamuka phezulu.
It's ridiculous because we don't have money.
Now I have to spend more on paraffin than I used to.
Their shacks were dismantled on Monday, but they are back to erect them.
You know what gives an African person dignity? It's only a house. And our bank, it's sheep and cattle. So we want to restore our dignity as well.
criminals are armed and dangerous than the police.
They are heavily equipped with AK-47.
What kind of society are we going to live in when our children are being killed in this manner?
If you have 10 generals in one country involved in corruption, you got a problem.
Police service is really in trouble.
Bekele can do so much.
All right, so last week we spent some bit of time just trying to understand the nature of this problem. So today we're going to focus on what is being done about this problem. And we're going to start with the most important question. How can we prevent medical aid fraud? I still have my guest, Dr. Lunginyati, Executive Director at MedScheme. And we have two other special guests in the middle. We have Vusi Makanda. Vusi is the Manager for Fraud, Waste and Abuse from Bonita's Medical Fund. Welcome to Health Talk, Vusi.
Thank you.
Right. And we also have Paul Midlane. Paul Midlane is Head of Forensics at MedScheme. Welcome to Health Talk, Paul.
Thank you.
Right. Let's start with this very important question. How do we prevent fraud? Okay. Perhaps let's start on the member side. Would you like to take us through, initiatives that we have in place to try and, educate our members not to be veered in this direction of fraud?
Sure. I think you say correctly, education is a very important thing because I don't think most people understand their medical scheme benefits, how they're structured, what they're for. I think there also is a lack of appreciation of the fact that when you're in medical aid, it's not just your money that you have access to. We're sharing the pool of money that everybody puts. If you consider, for example, that somebody who pays 5,000 Rand a month for medical aid in a year, they would have paid 60,000 Rand. But one hospital admission could easily cost 200,000 Rand or even R1 million. To have access to that kind of benefit means that you're counting on the fact that everybody's pooled their money together. Now, if one considers that, then you understand the importance of vigilance in how one utilizes their funds. I guess one of the easiest ways that members can be vigilant is to take an active interest in what happens with their funds. I don't know if members read their medical aid statements, but that's an easy way to start sensitizing oneself to what happens with your utilization. Then you can see whether or not there was a test that was charged when you didn't go for that test, or there's a doctor who claimed and you didn't actually see them. So those are simpler ways that one can start being aware of what can happen, but it's the active interest.
Okay. Yeah. So do you have programs at Bonitas, aimed at member education specifically around fraud?
Yes, Doctor, we do have those programs where we engage our members in trying and putting this thing across to them and make them aware of what medical aid fraud is. As Dr. Lungi has just alluded to the fact, it is also very important that members have interest in what the medical aid industry works. That's but one thing that we perhaps need to emphasize on our side, to say when we have these wellnesses, we need to talk to our members and make them aware of fraud in the industry.
Mm-hmm. Paul, clearly medical schemes and administrators have some programs in place that are aimed at, prevention of fraud amongst, let's just not talk about fraud. Obviously we're talking fraud, waste and abuse amongst medical professionals. Can you perhaps take us through some of those systems that you have in place, those intelligent IT systems that we have in place?
Yes, thank you. Obviously, when it comes to a healthcare event, there are so many claims associated to that. So you've got your medicine and your pharmacy, you've got your nurses, your hospitals, your doctors. There are so many claims. We process over 6 million claims a month. So in order to determine what is irregular and it was mentioned last week in terms of exception management, you need to look for outliers. You cannot look at everything. So what you do is you look for who's claiming 30 hours a day, who's claiming more on Sundays than on Mondays. You look for a whole bunch of different things, and if you use very fancy analytical systems that will highlight these outliers, and then you can engage with the doctor and say, please explain, or you can engage with the hospital and say, why is everyone in your hospital for 5 days for pneumonia but all the other hospitals 3 days? Those type of discussions you can only do if you follow the data and you follow the information. And once you do that exception management, it's really effective. And you do need a communication plan to members, because as was highlighted, in terms of banking, if money goes out of your account today, you get an SMS and you'll phone your bank immediately. But if a medical scheme's paid it, no one questions it, as long as it's paid. The only time you engage with your medical scheme is when a claim's not paid. And we need to change that conversation. We need to change that behavior. We need to say, if there's a pathology claim that you don't know, question it, phone and say, but I don't remember this.
Yeah.
If you've paid it with your pathology, let your medical scheme know so they don't double pay it.
Okay.
These are rough examples, but it's extremely important to curbing the opportunistic type of fraud, waste and abuse that's occurring.
Okay. So coming back to the issue of the profiling and engaging the outliers, is the rationale to catch the bad guys, as it were, or is it to proactively prevent fraud? And if so, how is it doing that?
Yes, so the best form of prevention, or the best form of stopping it, is prevention.
Right.
They call it, internationally, pay and chase, because we pay the claim and then we go and we look at data and we try to get the money back. If you can prevent that claim from being paid in the first place, that's first prize. We don't want to pay invalid claims. But as was previously mentioned, we do rely on faith. We rely on trust. We're not at that event to know that you had that knee surgery in hospital. We trust that the service was rendered. And only later on, if the data tells us otherwise, then we ask the right question. So if we can stop the money going out the bank account, that's first prize. But because medical schemes want their members to have access to healthcare as quickly as possible, we pay as quickly as possible. Medical schemes pay over 90% of the contribution, all goes back into healthcare. Okay. And that's a very critical distinction between us and...
Okay. So last week we spent some time looking at the whole notion of risk factors that are there. Let's go back to the members, for instance. A member that has a hospital cashback plan. And in these hard economic times, there's a need to get a bit of extra cash because there's other pressures. Now, how do you help such members? Anybody?
Doctor, it's hard to say this is how we can help that particular member. But what we expect from anyone who is in the medical aid or who's got the medical aid in his, we should be looking at it and say, is it the right thing for me to do that and go to hospital whereas I don't suffer from anything? If that particular person answers that question to say it's wrong, then they will know that it is not advisable for them to go there and just sleep in a hospital whereas they are not ill of any ailment.
Okay. That's from the member side. But how are we doing to prevent it happening? Remember we spoke about collusion with professionals.
One of the things we have done is we've started having active engagements with insurers of health cashback plans to get a better understanding of whether or not they're seeing increased claims in specific cases for specific providers in specific areas, under what circumstances, and then dovetailing that information so that we can be extra vigilant on our side if we know that somebody has a hospital cash plan, and then we ask questions much more intently at the time of requesting an authorization, for example. And so there we are trying to prevent unnecessary length of stays. And that's always a tricky thing to say, but we do try to be extra vigilant where we do know that there is a cashback plan, and the cashback plan providers also have highlighted on their side members or providers where they are seeing increased activity, and so that's how we try to prevent and look at areas.
Okay, let's at this stage get a comment or question from the audience. Yeah?
Thank you. I've got a few comments.
Just say who you are and what organization you represent. Yeah?
I'm Sibonelo Cele. I come from the Council for Medical Schemes. I'm a senior investigator at the CMS. I've got a few comments, and I want to just touch on what Eugene mentioned last week, the triage that informs fraud. I think we in order to respond meaningfully to this, we have to be mindful of that. There is an opportunity, there is rationalization, and in this instance, I think what is important is to first start remembering that health care cover is part of social security. The first leg that seems to have been accepted is the issue of trust not being an uppermost issue. Issue of ethics, it's not the uppermost issue. The response that we seem to be discussing more than anything, it's a reaction, and it is investigate and recover, or detect and prevent, but you are not responding to the causes. And I think it's something that we need to just try and put much more effort. Yes, data analytics and everything that we're talking about, but the cause for the conduct, is it a doctor who thinks he is entitled to more than what he's getting? How do we address that? The issue of a patient who thinks because I've been ill only once, I need to recover some money from the medical scheme. And this is where you then have to take the debate back to social security. Do you want to steal from the old and sick because this year you haven't claimed? I think it's that discussion that we need to add into a response to fraud.
All right. Let's hear one last.
I'm Elijah Nkosi. I represent the IPA Foundation of SA. My question is to the Afrocentric unit. That's to Paul. We don't condone any fraud as a provider group, but we are against the methodology that has been used in terms of where strangers just storm into the doctor's room, even though they would identify themselves, and then ask patients questions who are around the practice, go into the door where the records are, try to peruse records and to find clinical records, and ask who the locums who come and do locums here, and run the list of the locums and things like that. So that kind of approach where they disrupt a practice without even setting an appointment and then demand certain things, we think it's something that needs to be looked at. They shouldn't be doing it that way.
I think these are valid questions. We are going to address this question when we're now talking about, how this fraud is investigated. But very valid questions. We will make sure that they are addressed. Unfortunately, that's all we're going to have in this segment. We're going to come back. We have to go for a quick break. When we come back, we continue our discussion on prevention of fraud. Please stay with us.
Our stories.
How do I begin?
Our lives. When all seems to fail, we will raise our voices a bit louder for our justice.
I went into absolute shock. My whole body was shaky. I couldn't hold a phone, but there he was. I couldn't believe the nonchalance that they were still in the area 2 weeks later.
And in times when the justice system is not able to help us with our individual battles,
I'm willing to do anything. What are you doing? Nothing. Feeling sorry for yourself? No, it's not an option.
These are our stories on Cutting Edge Channel 404.
Technology is used for both positive and negative.
Some governments block the internet in times of protest.
With this internet blackout, it's impossible for me to do it, so I have to travel to Douala.
This act is a true violation of the rights of citizens.
In Africa, people are always coming up with innovative ways to use technology to solve some of their problems.
The more interesting piece of technology is actually the artificial intelligence.
AI, it's utilizing data to make your life easier.
On Network, we give you Africa's technology and social media news.
Catch Network with Spumelele Zondi every Saturday at 8:30 p.m. SABCnews.com is your one-stop digital portal to all the news you need. With a website that is easy to use on mobile, SABC News prides itself in being the primary source of public service content across multiple platforms. Watch live streams of all the big news events on the SABC News YouTube channel, which is one of the most viewed South African YouTube channels globally. And catch up on the best of SABC television and radio news. Follow breaking news on all of the SABC News social media platforms, interact with SABC News on Facebook, and stay connected on Twitter for the latest headlines and real-time updates by our reporters. SABC News, everywhere.
Dose of art and entertainment news. Tune into Trends every Saturday from 12 to 1.
Welcome back. We continue our discussion on medical aid fraud, this time looking at prevention with our special guests. It's a pleasure to welcome Dr. Elijah Nkosi. Dr. Nkosi is a general practitioner in practice and is also representing an organization called the IPA Foundation. Welcome to Health Talk.
Hi.
Right. And we also have Dr. Mani Tandrayan, who is the general manager at the South African Medical Association. Welcome to Health Talk, Dr. Tandrayan. And of course, we still have Vusi Makanda, who's manager of fraud, waste and abuse from Bonita's Medical Fund. Earlier on, we started talking about, prevention and what the schemes are doing in terms of detecting some aberrant behavior, perhaps early on and on the side of the medical professionals. And of course, we started talking about what it is that can be done to assist the members. But clearly, and as we clearly outlined earlier in the previous show, fraud is a fact, waste and abuse is a fact, and even though we're not saying every medical professional out there is fraudulent, but there certainly are those that have been, involved in fraud in one or another. So the question then is, what is the medical professional, what organizations like you, what is it that can be done to prevent this from happening? Let's start with you, Dr. Nkosi.
Our organization, the IPA Foundation of South Africa, has more than 5,000 providers who are part of the group and has contracts with major schemes and administrators. So we're able to get the profiling data from the schemes, and then we are able to then see where there's even abuse and wastage. And at times one can see if the claim is a bit fraudulent. But then what we then do, we have peer review. We've got a team that does peer review. Then that they are able to phone the doctor, give him his or her data, and then take him through his profile, just to show him or her where he's not meeting clinically appropriate guidelines. An example would be someone who's dispensing a lot of antibiotics for upper respiratory tract infection. The profiling data will be able to show that. The one who's over-admitting, the one who's upcoding, so it might show that. So we do that as a mentoring process to mentor our providers to ensure that they provide medically appropriate benefits. We don't condone any fraud. If there is fraud amongst our members or the scheme brings it to our attention, we will not defend that particular member. But then would want that doctor to be treated fairly. things like withholding of payment and then forcing a doctor into acknowledging debt. It's things that we don't accept.
We're going to address that, in a moment. Let's just get a perspective from the South African Medical Association. Yeah?
The South African Medical Association, we're a non-profit organization, a voluntary organization for doctors from GPs and board specialists. We've got private practice and those in the public sector. Generally, what we find is the complaints that we receive from our members is that they're being, unduly accused. Right. But we, on the other hand, as a professional organization, do CPDs and we try to educate our members on behavioral changes if there is any. But we find it's a very small percentage, less than 1%. I think 0.5% studies have shown that the HPCSA has actually found people of being fraudulent. So,
but you have a position statement on fraud to your members.
Yes, our position statement is don't commit fraud. I mean, right. Basically, we don't condone bad behavior, and therefore, as a professional organization, we ensure that we engage our members. Right. On that aspect of it, yeah.
Okay. But this is not, as we heard, it's not only about medical professionals. We heard that, it's possible that hospitals can be involved, pharmacies and allied health professionals and so on. Just your views in terms of how fraud can be prevented in those others.
The first point that I need to make, Doctor, is we treat the healthcare professionals as stakeholders within our fund. What that means is we expect them to also help us in curbing fraud, waste and abuse. I'm yet to hear or see a complaint coming from a doctor saying there was a member who was in my rooms and did A, B, C, and D. That's one. Two, we expect hospitals and others, other healthcare institutions, to also inform us of those kind of activities that happen in their respective areas. But of course, first point is, do they also know what fraud is, what waste and abuse is? If we engage in these talks and talk about these things openly, that will also make them also understand what we have been doing maybe was waste or was fraud or was abuse. So communication and engagement among stakeholders is very important.
Okay. Let me get a comment from the audience, anybody from the audience. I mean, what should be done around, for instance, pharmacists, because there's quite a large area where some of this waste is coming from. Anybody?
I think when you're talking about waste and abuse, what you need is to have a strong peer review mechanism, because that should be the first port of call. And what we should be doing is cooperating with each other in ensuring that there are peer review forums in relation to the statutory bodies, because that's where the action can be taken against the practitioners. But it needs to be about peers. And if we go back to establishing those properly, then you're going to begin to start on a collegial basis by correcting people that may sometimes, that's how they practice, they don't know anyway, and they can be shown how to practice properly. So peer review has to be a key component of dealing with waste and abuse from the professional side. What you do with members that come and want certain things, I want you to see my brother who's not on the medical aid, that's going to be a difficult one when you don't see any action, when people have been found to have colluded with members and nothing happens to those members. But I think it's up to, we don't have oversight over members. They are your members. But you can sit with us and say, this is what you want you to do with respect to members that approach practitioners, and we need to see action happen in that regard. Because remember, you must be prepared to reduce your numbers by half on a medical aid. And as a practitioner, you must also be prepared that your patient numbers will go down. But unless we sit and openly negotiate with each other, we will never get to the end of this problem.
Let's get another comment.
I'd also like to just add that when one looks at errand providers, and I certainly know from an metropolitan health perspective when we analyze data, and I'm very sure it's the same with MedScheme as well as Discovery. We're not talking about outliers of a 0.11% or a very slight deviation from the norm. We are talking about an outlier that is really an outlier. One example that I had recently in the week that I had to write a letter to ask, please explain this, is a general practitioner who charged for ECGs, 620 electrocardiograms that he did in a year, all of them on a treadmill. He didn't claim a single ECG that was done as a resting ECG. He only claimed the most expensive code for ECG. So if you walk into his surgery with chest pain, he will run you into a heart attack on that treadmill. Or at least that's what the claims data shows
All
us.
right, let's give the last comment to Katlego.
Yeah, thank you, Doc. I think from my perspective, fraud is an industry issue.
Right.
And we must stop treating it as individuals. It's not a competition issue for the industry. We must attack it in a unified voice. The second area around prevention, I think we should also concentrate on deterrence of fraud. It means going the full spectrum. You investigate, you make your findings, and then you go the professional route and the criminal route. It will serve as a bigger deterrence when people start getting sentences. Somebody's in jail for 12 years or for 20 years for defrauding a scheme. And I think that will bring the seriousness in how we deal with it. It will help prevent.
Right. So there appears to be lots of dissatisfaction around how fraud is being investigated, especially amongst medical professionals. But why is that? That after the break. Please stay with us.
SABCnews.com is your one-stop digital portal to all the news you need. With a website that is easy to use on mobile, SABC News prides itself in being the primary source of public service content across multiple platforms. Watch live streams of all the big news events on the SABC News YouTube channel, which is one of the most viewed South African YouTube channels globally. And catch up on the best of SABC television and radio news. Follow breaking news on all of the SABC News social media platforms, interact with SABC News on Facebook, and stay connected on Twitter for the latest headlines and real-time updates by our reporters. SABC News, everywhere.
Violent protests have spread throughout the province for a second week now.
It shows that the ANC here cannot put the people first, and services have failed here. That's why this Northwest becomes a very important province.
We've almost got brought. Next. Ja, voor in je bakje is een lighter. Kom, maak zit in je kop, pak.
At the end of the day, Babang, the maternal death and all that, we are to be blamed because of overcrowding of the patient.
I will build a great, great wall on our southern border, and I will have Mexico pay for that wall. And nobody builds walls better than me, believe me.
How safe is social media? 25 years into democracy and we're still battling with apartheid. Are we really the so-called rainbow nation?
If we can go there, they will beat us something or chase us away. Or kill you.
Not forgetting the dangers of substance abuse.
When he brought those things and came to us, it was looking so tasty with crushed lemons and strawberry and colorful straws.
Importance of education for all. Is the judiciary and government failing the people of South Africa? These are some of our stories on Cutting Edge. Catch it every Sunday at 5:30.
Welcome back, and thank you so much for staying with us. We're discussing medical aid fraud, and in this segment we're going to be talking about, how is fraud, waste and abuse investigated, and why is there such animosity and what's an unhappiness amongst professionals especially. Well, to help us with this is our special guest Ishmael Mohapi, is a Senior Manager of Operations and Risk at GEMS Medical Scheme. Welcome to Health Talk.
Thank you, Dr.
And in the middle we have Dr. Prudence Buthelezi, who's a practicing general practitioner and represents an organization that I hope I will say accurately is the Healthcare Professionals Association.
National Healthcare Professional Association.
There you go. National Healthcare Professional Association of South Africa. Welcome to Health Talk.
Thank you, Dr.
And of course, we introduced Paul Midlane, Head of Forensics at MedScheme a little earlier. So perhaps let's start with you, Ishmael, in terms of the methods that are employed to investigate. I mean, we spent quite a bit of time talking about the profiling to detect perhaps possible fraud, waste and abuse. When there are indications that something may be fraudulent, what are the methods that are employed to investigate that, to gather more information, as it were?
Okay, thank you. You would understand that we would have units of investigative units, which we now call forensic units, and they rely on information, information coming from the hotline, where members, providers, they report fraud. They also rely on analytics, which the other speakers have already spoken to, where data has been analyzed. Now somebody has to look at this. Now we employ what you call an audit-based investigation methodology, meaning that you look at data, you write an anomaly letter, which you will send to a service provider. But the first point of contact is that informing the service provider that you have been selected for a review. And it's an audit-based investigation. And we always say it's not a fraud investigation, but it's an irregularity that has been demonstrated in the profiling that was conducted. And the providers afforded an opportunity to respond to the allegations that are made. And as part of that, we investigators, some of them are not clinical, but they work under guidance of a clinical person who will be able to can engage with the provider at their level of expertise. And thereafter, once the information comes back from a service provider, and sometimes it's an admission that I have actually submitted irregular claim. And in instances where a provider, sometimes after being afforded an opportunity to respond to allegation, they don't respond at all. You do engage members, you obtained affidavits from members, also relating to the service that they've rendered. And that is packaged. We, from a GEMS perspective, we have a forum where we have legal people who sit in that. We have clinical people, we have operational people, business people. And then we evaluate the case to see, is it irregular? You evaluate it on following basis. Is the conduct of a service provider against the scheme rules? Is it against the Medical Schemes Act per se? Is it an offense, maybe also in terms of a criminal offense? And then we take action in terms of that, and we have different sanctions. Yeah.
We'll come back to the actions and the sanctions in the later segment. But let's get a perspective. I'm going to come back to you, Dr. Buthelezi, because I would like to know the other side's perspective from a medical professional. But for now, let's focus on what's happening under MedScheme, for instance, in terms of methods that are employed. One criticism sometimes is that methods that are employed are often illegal. Your comment on that?
Yes, thank you. Thank you for the opportunity. I think very often there is a misperception, and I fully support what Ishmael has said, is that we actually don't use the word fraud or waste or abuse. We have very strict frameworks and processes that we've put in place where you have to engage with the provider. They call it, in legal terms, that LD Ultram Partem rule. They deserve an opportunity to respond. We follow the data, and we focus on entitlement. We are not actually concerned about what was your intention with this billing. It's what is the scheme out of pocket? Were you entitled to payment? And that is our focus. Because at the end of the day, it's members' money that has been misspent. And very often the doctors, it was not intentional. They did not know. They did not understand the codes. We completely understand that. However, you have been overpaid, or you have
claimed incorrectly, and the scheme, have a fiduciary duty to look after the members' money. So in terms of processes, they are very strict. I mean, they're very transparent. We do engage with the doctors. And like you say, the healthcare providers and the pharmacies, we write to them and we ask for explanations. And only under very limited circumstances, you would have been aware last year of the bogus doctors. And there was a scourge of people posing as doctors, putting on a lab coat, putting on a stethoscope, taking someone else's practice number and treating people. And the only way you ever get to verify if there is a bogus doctor is to go to the premises and look. You can't tell that from claims data.
Okay. Dr. Buthelezi, why is there such unhappiness around these methods? Earlier on, in fact, you quoted as saying that these profiling methods and the investigations appear to be targeting especially black professionals. Please expand on that.
Okay. As in SCPA, I want to emphasize that we really don't promote a fraud. If somebody is caught doing fraud, she must be open a case at the police station, and that's it. What we don't like is the principles that they are using as medical aid. Firstly, they are violating our rights of privacy. When they come with the camera, as you know, as a doctor, that you even yourself, you cannot take a photo of your patients, but they come with the cameras inside our offices, and then they demand the file of the patient. What about the confidentiality? We know from National Health Acts, the confidentiality of the patient, they want to divulge that information to them without the consent from the patient. So we find ourselves being detected by medical aid. And it all starts from the tariffs that they give to us. Maybe we can start there. That are we paid what we worth? Are we paid what is enough?
Okay. That's a separate discussion altogether. But let's just come back around the modus operandi that she talks about. And I mean, anybody can respond as such. Clandestine ways, cameras and so on, confidentiality and so on?
Yeah, just a statement. I mean, from government employees medical schemes, we do not employ those tactics. We don't do probes. But as my colleagues have said, is that in certain instances, you would realize that you are told that there is a particular practice at this particular place. We're sitting and looking at data. There is sometimes information that comes in to say, if you go to that particular premises, you'll find there's nothing happening there. And that is the instances where you send out investigators on the ground just to test, do we have that practice in place? And when you get there, you find, look, it's a soccer field, but we've been paying millions to this provider for years. But at the premises where he was supposed to be operating from, nobody's there. So there are certain circumstances where people will go out and interview members and where they will interview providers. But yeah, we don't do programs.
We're fast running out of time in this, but I'd like to get a comment from the audience. Yeah.
Thank you. Sibonelo from the Council for Medical Schemes. I'm a senior investigator. We have, as a regulator, received complaints that are being mentioned here. I think what is important to stress is that there are two ends of the extremities on this one. There are those ones who are conducting themselves within the framework of the law, that is in terms of Section 59, read with Regulation 6, and there are those ones who we have received evidence of cameras having been used on doctors as well. So what has become apparent for us is that there is no adequate oversight on these practices. There ought to be an adjudicative oversight. There is no judicial oversight on the processes. The signing or the settlement, entering into agreements, is a natural operation of the law. We say there is nothing wrong with that. However, it must happen in accordance with the rules, with the rule of law, in accordance with the Constitution, under judicial oversight.
Okay, let me give a quick opportunity to Paul, because we literally have run out of time in this segment. Do you want to just respond to some of these allegations, some of these statements that have been made?
No, I mean, we're more than comfortable with our processes, and I mean, our job is to protect the interests of the members, and, you know, we're open to whatever type of mediation or arbitration or any type of judicial oversight that we're talking. We go to court all the time, and every provider has a right to take us to court, every hospital, and there are good legal precedents. The unfortunate part is, the medical industry is a little bit behind because everything is based on trust and good faith. We need to now start, closing the floodgates and asking the right questions.
Okay, that's where we're going to have to leave it. We go for a quick break. When we come back, we continue our discussion. Final segment on this subject. Please stay with us.
Name the Cape Town Airport, Winnie Mandela Airport. Koi was the first people here. Malema admitted it. So why does Malema not back Pretoria?
People are continuing doing things in his name. We need much more active distancing himself from that, and say, not in my name.
We are hereby advising the NEC to withdraw their decision of not allowing people to support Mr. JZ Zuma.
Unity in our alliance is a process. Unity is not a one-day event. It does take time.
Welcome back. We're in our final segment of our discussion on medical aid fraud, and we're looking at, the consequences, possible consequences that can follow from proven fraud. I suppose we can extend that to waste and abuse with our special guest, Ishmael Mokhapi, Senior Manager of Operations Risk at GEMS, and Dr. Eugene Berger, Head of Claims Risk at Metropolitan Health, and of course Dr. Kosili Tlape, somebody that we welcome, who's obviously been participating in this show. He's the president of the Health Professional Council of South Africa. Welcome, by the way, formally to Health.
Thank you, and good morning, or good morning to the viewers and listeners.
Okay, so let's get back to that subject of, obviously we try to deal with this unhappiness that's there around, the methods that are used. So when you do then finally get, and I'm going to start with you, Dr. Berger, when we do then finally get information that suggests that, this is fraudulent. By the way, as a matter of principle, is it the onus on the provider, on the professional, to prove innocence, or is the onus on your side to prove wrongdoing? Or is it a bit of both?
A bit of both. I think the onus on the provider to provide certain information if it's reasonable to provide it. I think if we can establish a batting order of precedence here, is the first thing we would like to avoid is that harm be done to patients. Because we must remember that fraudulent behavior, if so proven and is the case, can actually be harmful to patients. So it must be stopped. But we must also take into account that, it's not in anybody's interest to decapitate, every provider that's errant or has wasteful or abusive behavior or even fraudulent behavior. They may still be good doctors or nurses or whatever healthcare practitioners. Perhaps the snake's head does not have to be chopped off. It must just be taught not to bite. So we would like to correct, and what we want to do is herd those back to the median. They were outliers for a reason. Yeah. They were further investigated. They were given ample time, ample evidence. For example,
the gentleman with the ECG I mentioned earlier in one of the snippets, is we've asked him just to provide us with the serial number of his treadmill, or even just to take a photo on his phone and send it to us. He didn't. He can't. He doesn't have it. But he's claiming that he's doing this. Now, at some point, we have to intervene, surely.
Let's come back to the issue of the pocket now. The decision to say, we're now going to withhold payment, we're not going to pay you, or that we're going to start paying your patients and not you. What informs that kind of decision?
Yeah. So, obviously, you must understand that medical aid fraud will have a serious implication and repercussion to the scheme viability. And also, you do not want to pay incorrect claims. So, first of all, you need to look at what does the Medical Schemes Act say. You need to act within the regulation. The Act allows you, if you have a problem with a specific claim, you mentioned Regulation 5, Regulation 6, to say suspend payment and request information from the service provider. So you need to follow that first of all, to say, can you suspend? But you must do that within the law. Now, the other fact also, the Act also allows you to say, if you have paid a claim, bona fide, you can also reverse that particular action. And that can be offset on future claims of the provider. That is Section 15.3. So we follow what the legislation says. Now, the scheme also, what it does is that the Act says you must either pay the provider or the member. Now, where you have now determined that there is a huge risk on this provider's claiming behavior, do you still continue paying this provider? Because if you have found a lot of instances of irregular claims coming from that provider. Now you have a challenge in the sense that I would rather go, our members are allowed to say, no, provider, we won't pay you directly. Okay. But you can still consult with our members and they will pay cash. And that process is that you need to engage the provider, you need to inform him. Okay. Yeah.
Dr. Lezape, I'd like you to respond, but also there's been criticism leveled at the Health Professions Council that in their bid to try and arrest this problem of fraud, cases get referred to HPCSA, but nothing is done or not enough is done about them. Please, I'd like you to respond to that.
Well, I'll start elsewhere before I come to that. Firstly, the issue of cultural differences. He says you could make a snake not bite. Where I come from, all snakes bite. But having done with that cultural difference, I'll come back to the issue that is being raised. Firstly, we need to act lawfully so that we can empower each other to do our jobs properly. Entrapment requires to be authorized by the NPA. So when you've entrapped someone and you've done it unlawfully, you compromises the process going forward. Secondly, this issue of extrapolation. They find you guilty of one charge and they say for 5 years, we multiply it by 500 and you now got 500 charges. That's extortion. Now, when we get presented with arrangements where one charge has been proven and from something they multiply it because of the practice pattern, we have difficulty when you come into a legal process because they say, but this person was only charged with one count, but you've now multiplied it and you've now got, and they claim extortion. It makes things difficult for us. So let us go back to the rule of law and respect the law. And if a person has been convicted, even if it's one count of 18 rands of fraud and the court has said you are fraudulent, we're going to deal with you harshly because there's a conviction and it expedites our processes.
But is the Healthcare Professions Council dealing with the cases that are referred to them?
Well, yes, we're dealing with the cases that are referred. We can give you the stats of how many serious cases has been dealt with, and those stats are out there, and we can give you the censures that have been given that include one removal, countless suspensions, and fines. Okay. But if we have a criminal conviction, there will be more erasures. And that's what we would like to see. Now, to go back to the one issue, the problem is that when you're talking about waste and abuse, it's professional behavior. Now, when you start doing that and we're not coming up with mechanisms to create peer review structures, then you've got an investigator and you get somebody that is not a peer that's coming to do the investigation, the whole thing becomes pear-shaped. What we have allowed as professionals is our profession to be deprofessionalized, where people that are not professional get involved in professional matters. And we need to stand firm and say, if it's about professional misconduct of a practitioner, let professionals, let peers review that behavior so that we can then come out. And unless the funders respect us as professionals and accept that professional issues must be left to the profession, where we self-regulate, we will end up with all these issues of cases that come, they become legalistic, they are legally poor because they use their economic power of saying, we can't pay you. And people, they have to understand that they are empowered to collect the money from the practitioner. Is fraud is proven.
Unfortunately, we've run out of time. I'm going to give each of you 20 seconds, your concluding thoughts on how we're dealing with the problem of fraud from the provider side and from the member side. 20 seconds.
Yeah, so mine is that the industry, we need to collaborate. And when I say collaboration, I'm not saying only the medical schemes or administrators, but I'm talking about also association, so that they can also realize and also partake in also the exercise that we're doing in terms of combating of fraud, waste and abuse. I think collaboration is key.
Dr. Berger?
More corrective behavior, less punitive, and when the council acts, the 2 or 3 years that it sometimes lapses before there's a decision, what must we do with payments to that provider that we are highly suspicious of? Continue paying at the expense of a scheme?
I'm afraid that's where we're going to have to leave it.
No, I must also surmise. No, this
I'm
is
going
not
to give you
fair.
10 seconds.
You can give me 10 seconds. We can talk about that issue. But this issue of withholding payment is insensitive of the different economic circumstances of the people in South Africa. My patients cannot pay upfront for me. So when you do that, you do not care for your own members, because in our profiles, they can't pay us upfront. There needs to be a better solution. And if you think you care about your members,
I'm sure it's a challenge to all of us to try and devise new methods. I'm afraid that's all we have for you today. That's Dr. Khosi Letlape, President of HPCSA, Dr. Eugene Berger from Metropolitan Health, Ishmael Mokhapi from GEMS, and of course all the other guests that we've had on the panel and on the audience. Thank you very much for your contribution. Thank you very much for your time. And for you folk at home, thank you so much for staying with us and watching this very informative show. We're back on your screen again next week, same time. And until then, please do take care and just stay out of trouble. Cheers.